Welcome to the second webinar in the 6-part series sponsored by ConvaTec. Today I'll be talking about step 1, wound and peri-wound cleansing. Hello, I'm Terry Swanson and I'm a nurse practitioner in wound management. Today I'll be talking about the consensus document going through the review of wound and peri-wound hygiene. I'll be talking about the goals of wound and peri-wound cleansing, the how-to and what solutions, both for wound cleansing and the peri-wound. I'll introduce hyperkeratosis, which is included in the document, as well as some wound dressing procedures, as well as tips for practice. As the photos show, that the visualization of wound cleansing can be quite traumatic. So I often show my patients the before and the after. The wound hygiene document, the international consensus, define hard-to-heal wounds with an early anti-biofilm intervention strategy, or wound hygiene, was published in the journal Wound Care this year. We met face-to-face in London in 2019. I felt honored to be invited to participate. This document is free to download. And I'll be switching to the next slide, so you won't be able to get the full link, but if you just Google wound hygiene, you should be able to get the document and the other details provided in there. As you can see, this is experts in the field providing practical advice. Today I'm going to be focusing on therapeutic cleansing of the wound and the peri-wound. This consensus document is well referenced. It provides you definitions within the document. It has sections called myth busting, so it provides the myth as well as the rationale to demyth that. There are practical applications with all levels of experience and knowledge. So 4 easy steps. In each subsequent webinar, I will be providing more information on the steps and implementation. The rationale and the importance of wound hygiene. We all are aware of the term hygiene. It should make sense to you and be familiar to you. So that is why they came up with coined the term wound hygiene. I've given you 4 examples. Oral hygiene has a strong correlation with wound hygiene as well practiced, and the importance of doing so is well accepted. Any form of hygiene requires a solution paste with surfactants cleansing properties, as well as the mechanical action. This is done frequently, and the quality of the application must be robust. An example with toothpaste has anti-biofilm ingredients married with the mechanical activity of brushing to dislodge and remove the biofilm. The mouthwash is the antiseptic solution, or the rinsing of the biofilm. And then you have flossing, which is the mechanical removal and dislodges even the larger particles. We have used that analogy with our dental counterparts for years, and they have been the early adopters and developments in the human biome. Personal hygiene can influence wound healing. It also, when a patient has good personal hygiene, can improve their well-being. Hand hygiene, we're all aware as healthcare professionals. But in today's pandemic, we know that many people are being taught outside the healthcare arena. We've all talked about good hand hygiene for years, but it's not only the frequency, but it's also the quality of how you do it. So the commercials are talking about going in between the fingers and getting the fingertips and the thumb. So it is the frequency and the quality of the action. And with limb hygiene in Australia and Asia Pacific, we've been talking about with each dressing change that we require to wash around the peri-wound. Hard to heal wounds. So this whole document is based around hard to heal wounds. And so many people from the first webinar have been talking about, should I, is normal saline okay? And I will go through some of those components of the attributes of the different solutions. But keep in mind when you're watching this webinar that I'm talking about hard to heal. Now, in the document, it has this definition. It's kind of small to read on the screen, so I provided a bit of a summary. So a hard to heal wound is a wound that has failed to respond to evidence-based standard of care. So if you've determined that this is a healable wound, it's not malignant, that it has enough blood flow for healing, And in spite of that and your appropriate care, it still hasn't gone on to heal, then it is a hard to heal wound, and hard to heal wounds equal biofilm. And that is regardless of the duration of the wound. In 2016, the International Wound Infection Institute actually removed the time frame in its definition of a chronic wound as well. So if you have slough, increased size, or increased exudate, then it is deemed, according to this definition, is hard to heal. And we've known since the 1990s that there's an imbalance between a healing wound fluid and the chronic wound fluid. And within that imbalance, you have increased pro-inflammatory cytokines such as TNF-alpha, or tumor necrosis factor alpha. You have increased metalloproteases, or matrix metalloproteases. These, in too high numbers, degrade the wound bed, and the TIMPs that are trying to control and keep them in appropriate numbers are also decreased. You also have increased pH. So with this imbalance, and all our strategies provided in this document are an attempt to reboot that wound, remove the senescent cells, improve that meiotic activity, and get it back into balance. So with the wound and peri-wound cleansing, we do distinctly separate. So the wound is cleaning the wound bed sufficiently to clean away the devitalized tissue, any wound debris, remaining products, foreign objects such as sutures, as well as biofilm. The peri-wound cleans at least 10 to 20 centimeters beyond the wound edge. Anywhere that there was a dressing needs to be cleansed. Anywhere that you've had a bandage or a larger dressing needs to be cleansed. And we do, the sequencing of this is important, and I'll talk about in down the track on this other slides. Now, this concept of therapeutic wound and peri-wound cleansing is not unique. So George Rodeheaver, who I consider the godfather of wound cleansing, has been published since the early 1990s and before. He coined the phrase that you shouldn't put anything into the wound that you wouldn't put into your eye. But the wheels have turned again, and Randy Walcott, a clinician scientist, a researcher, has challenged Rodeheaver in that concept with his conceptualization that the wound is not a garden, but a war zone. So we need to use, on a short-term basis until you have that healing trajectory, to use antiseptics in a contaminated, infected wound where it is required. The reasons to cleanse I've summarized here, and that is to disrupt the biofilm, to cleanse away any excess exudate, to prepare the wound for cultures, wound dressings, or technology, to assist in wound assessment. Many times you cannot determine if the wound edges are attached, and that tells you the story of your wound, and you're giving you some wound healing indicators. Also, there are many dressings that tend to desiccate at the wound edges anyway. And the wound edges are important. That's where the healing cells come from, so they need to be clean and moist and free of debris. The cleansing action removes, as I talked about before, the foreign bodies, debris, but also remnant dressing. Now, this happens more often than we care to admit. And I once had a microbiologist call me up and say, Terry, what dressing has this patient been having put on? And I hadn't seen the patient for about a month, but I looked up on the computer, and the patient had had an alginate, and it had taken on the contour and looked like the wound bed, and they had actually biopsied that. And then as soon as I told him it was an alginate, he goes, that's what it is. And then I've also had patients come in and said, the nurse told me that my wound has healed. And I said, well, let me just have a look. And I've taken the tweezers and I've lifted up that, because it didn't look like normal healed tissue to me. And it was actually the remnant dressing product that had dried out and taken on the contour of the wound. So I lifted that up to reveal it was healing, but it had not healed. So all that dressing has to be removed each time, whether it's deemed biodegradable or not. And of course, all of this is in an effort to decrease the bile burden, and in particular disrupt the biofilm. So before we do any procedure, I like to do what I call the 3 A's. That is to anticipate that you're going to elicit or initiate pain or discomfort for these patients, so that I encourage my patients to administer a simple analgesic before they come, and then assess the effectiveness of that. Now, a patient's perception of pain can be influenced by many factors. Psychological and environmental are two main ones. And so whether it be their age, gender, culture, or their current state of anxiety, we know that patients with high level of anxiety stress report increased levels of pain. Environmental may be simply the timing of the procedure, the setting, level of noise. I know as a previous patient that when a procedure was being done on me, the curtain hadn't been closed. Even though they shut the door, I was afraid that somebody would open the door and see me in all my glory, and it increased my anxiety. Certainly didn't allow me to become comfortable with the procedure that was occurring. So make sure that when you're doing a procedure of any sort, that you provide that patient with the respect and privacy that they deserve, position them in a comfortable position, and not only for them, but also for you, so it's ergonomic. Anytime that we cleanse or debride, we can elicit operative pain, and so we have to anticipate that and keep working towards so that it's as manageable for the patient as possible. And there are some strategies such as allowing them to go at their pace. If you tell a patient, I'm going to do this treatment for 5 minutes, then keep your word. Procedural pain, such as what we do every time we do a dressing procedures, and that's removing the dressing as well as the application. And even some of the atraumatic dressings can, on the right patient, elicit some discomfort. So many times just using a little bit of water to take those dressing, and always, doesn't matter the type of dressing, to do it with care. Incidental pain, it relates to movement-related activities, and certainly if the dressing's been on for several days or a week, it starts to dry out and can stick, and patients do often report that. So you can ameliorate that by changing it more frequently. Certainly if you have a compression bandage on and it slips down, that can increase the discomfort for that patient. Not only do these patients have wounds, but they can also have other comorbidities and diseases, so they can have background pain unrelated to what you're doing to that patient. So it's getting a pain history. And for some patients who come into our services, wound healing is not the first priority. It's getting that pain under control. So remember the 3 A's: to anticipate, administer, and assess, to get the pain under control. Now, just with the WHO, the World Health Organization ladder, pain scale, and management, I'm not going to go into great detail, but just a little bit to talk about some of the adjunctive therapies. So diversion therapy such as music or augmented reality using some of the goggles, talking to your patient about their dog or whatever they're gardening, whatever their interests are, and checking in with them as you're doing the procedure to make sure that they're doing okay. Now, my mantra for several years now has been to stop anointing wounds. And many of the questions from the last webinar was around what is therapeutic cleansing, and I go into it in great detail. But as you can see, this is passive irrigation, and this happens a lot when you've got an ampule, 10 ml ampule of saline or sterile water, and you flow it over the wound. You take a little bit of gauze. Well, to me, that is anointing the wound. What we need is therapeutic cleansing to remove those surface contaminants, that loose debris, slough, soft necrosis, the microbes and remnants of previous dressings, all of that. And standard saline or water rinses do not remove biofilm, and they're not effective. So we need to stop anointing wounds. Anytime that you are going to be doing a wound dressing procedure, then you need to have a PPE, so personal protective equipment. We know that for any procedure that we need gloves. We take off most times the dressings off with non-sterile. The use of sterile is depending on the risk and the complexity of the wound dressing procedure that you're about to approach. Anytime that you are doing any cleansing, you need an apron or a gown to reduce that splash and contamination of your clothing. The mask and the shield depends on if you're doing therapeutic cleansing or if there's an increased risk. When I'm doing low-frequency ultrasound debridement, you can see this is a picture of Dot Weir here doing ultrasound debridement. She has the gloves, she has the gown, and the mask and the shield to protect. I also wear a surgical cap to prevent contamination to my hair. So it depends on the complexity and what you're doing. Remember that in our clinic we wear gowns all the time because we don't want to cross-contaminate. So if you're going from patient to patient, putting a gown while you do that dressing procedure is one way to interrupt that step of cross-contamination. So what are the the techniques for therapeutic wound cleansing? There are a few options. So there is the irrigation, and this is becoming less popular because of the requirements for protection for the patient and for you. But I'll talk about the streaming, continuous pulsed irrigation and the pulsatile lavage. More common these days is the monofilament or microfiber pads, and then the moistened gauze if you have none of the available. That's in anybody's hands. But what we do recommend is an antiseptic solution or an antimicrobial wash with the surfactant to add that antimicrobial, antibiofilm activity along with the mechanical. So if you are doing therapeutic irrigation, they talk about pounds per square inch. And the therapeutic range is between 4 and 15 psi, pounds per square inch. So there's a variation of if you have loose necrotic tissue, you need sort of the higher levels of 8 to 15, and you can alter that pressure through the size of the syringe and the gauge of the needle. And Wendy White, in her chapter in the book Wound Management for the Advanced Clinician, provides you these. And for granulation and epithelial tissue, you require less pressure, and that's 4 to 8 psi. If you're wanting to decrease the dispersal, these are some of the devices that you can put onto your syringe. And if you have none of the commercial ones, you can see in the corner is a medicine cup. You can cut a little hole in there to put in so that it tries to keep the fluid at the surface to decrease that dispersal. So the power devices, the pulsatile lavage, found mainly in the emergency departments, in the theater settings. They do a good job. This is what they do when they're doing washouts many times, or if a patient comes in with an abrasion from road rash to get that gravel and that dirt out of the wound. So the cleansing pads or debridement pads, however you want to term them, are becoming more common. If you look at the top wound, that certainly requires cleaning and debridement. So the pads are quite good. You moisten them. The manufacturers say that you can use saline. In this document, we again recommend that you use the antiseptic or antimicrobial wound cleansers, and you keep cleansing until your wound looks at the bottom. And there are several types available here in Australia. You use a circular motion for about 2 minutes. Because you're trying to remove not only the visible but the non-visible. And remember that biofilm isn't visible to the naked eye, but it is present both on the surface and the deeper tissue. So when we're doing the cleaning, we're cleaning the wound bed. And in one of the webinars, I talk about refashioning the wound edge and then cleaning the peri-wound. So gauze or foam scrubbing. So this is sterile gauze with the antiseptic solution or a sterile foam. You remembering that any time that you're doing a procedure, you need to follow your local protocols and procedures. The evidence that I've been able to determine, and certainly recommended in this document, that it is effective, maybe not as effective as the pads, maybe slightly more painful, but is a good second choice if you do not have the pads available. It's less expensive, and it can be used from a novice to the expert. When I'm using a moistened gauze, so I'll put the antiseptic moistened gauze on the wound and then wash the peri-wound to wash the limb. But I'm not going to just throw that gauze away. So I use that same gauze to start the process. So I'm cleaning the wound and then cleaning the wound edges. I may use other modalities of cleansing and debridement, but I'm using that opportunity of that moistened gauze to start the process. A lot of these surfactants and these antiseptic wound cleansing options are very good at removing that crusting and softening that crusting. The surfactant helps lift it and break down the proteinaceous dried exudates. Even on acute wounds, when you have sutures and there's been a lot of crusting on that, putting a pack on there for a few minutes is really good to kind of soften that crusting, so then you can cleanse those sutures and make the suture removal that much easier. So just a quick review of what surfactants are. So they have a hydrophobic head and a hydrophilic tail. So they're in constant motion, sort of a rinsing activity, so that it has a cleansing activity at a microscopic level, and it softens, loosens, and traps the wound debris. There is some evidence of antibiofilm properties. So factors that influence the efficacy of cleansers, the antiseptic stewardship. Last time I talked about antimicrobial stewardship. This time I've talked about antiseptic stewardship. It is a thing. So this author provided some lists of the factors that influence, and pH of the wound is one. The type and the amount of the wound organisms, and whether it is planktonic versus biofilm, understanding that with the biofilm, they are more tolerant to the antimicrobials, whether it be an antibiotic or an antiseptic. The type and the amount of the wound fluid or exudate. The exposure time, I just talked about the amount of exposure to the wound. And when you're looking at your solution that you're choosing for your facility, also look at the company's testing and how they tested it. Did they test it for 24 hours? Did they test it for 10 hours? Was it in the laboratory, in vitro, or was it in more of a clinical setting or in on an animal type model, and try to extrapolate that into your practice. So you need to review how these products were actually tested, and a lot of them who've been around for a long time have actually had to go back and retest them for biofilm because they were tested for planktonic microbes at the time. Also, there's the concentration of the solution, and we recommend some of the, in this document, some of the consensus document, more of the modern antiseptics, but there's still a lot of the older antiseptics that have a bit more cytotoxicity, and that's related many times to the concentration of the solution. Now, one of the questions that came from the first webinar was in this consensus document on wound hygiene, it doesn't list an antiseptic such as povidone iodine. But in the International Wound Infection Institute document, it does. And there are some inconsistencies in the literature. What this document was trying to move to more of the more modern. It doesn't mean that it doesn't have a role. And certainly if you, remembering that we're talking about hard to heal wounds, if that's what you have available, then you need to just follow the guidelines for that particular product. Also, the genetics of the individual, and if we look at cancer science, that the genomics of, they are testing the genetics of that person and also the cancer, and they target that according to that. And we know that some people are responders for certain products and non-responders. So there may be a time in the future where we can do a genetic evaluation of these patients and say, no, this type of antimicrobial might be better for you. I've put an article there by Johanny Malone et al. In 2017 talking about some of the exposure times of wound solutions that I have found very interesting and would recommend for you to review. Cleaning of the peri-wound, I can't emphasize enough how important it is to clean that peri-wound. I talked about last time where some of these patients go for 6 months, and you've written in and told me that sometimes as long as 2 years without the patient having their limb cleansed. And there's really no excuse for that. And I'll go through some of the ways to clean as well. But the reason we do it is to remove that surface microbes and to prove their well-being. It can be as simple as using potable water and a cloth to start it off, and rubbing in the antiseptic with that. You can use sponges, chemical agents, but as you can see from these photos, if I hadn't removed all that, and you can see from the timestamp, there's about 15 minutes from the top to the bottom, and it provides me a good, clean wound to assess and know that the dressing product that I'm going to put on that wound actually will be dealing with the wound bed instead of all that surface substance on top. Now, with scales or hyperkeratotic, and this is quite common in patients who have venous leg ulceration, and the goal is prevention, treatment, and maintenance. And you can see from this photo that the patient actually came in, they're in hospital, as you can see from the photo, on their left knee, they've got an injury down to bone where they fell. So I was cleaning that too, but the look at the legs, that patient hadn't had her legs washed for quite a long time. That thick, scaly outer layer of skin was so caked on. It took me, as you see, it's about 45 minutes in this photo to soak, to use my forceps. I think, got a curette and scraped some of that off. This is, you don't have to do it, if it's this bad, you don't have to do it all in one sitting. It's going to take some softening, and I had the time and the patient had the tolerance to allow me to do that for so long. So don't feel you have to do it all at once, but it is something you do have to work on. So the treatment is based on removing that hyperkeratosis. Now, I'm not talking about hyperkeratosis that you get from pressure, that you see very commonly with your diabetic foot ulcer. So this is basically what I'm talking about, is the scaling or that thickening of the skin. And it can get quite itchy, and also you can get cracking in the skin because of the dryness of that, and then that is a portal of entry for microbes to enter. So it is very important that that is dealt with, to use products and cleansing to remove that hyperkeratosis. Now, this is a document that I came across from Wounds UK. This was published back in 2015. And this is the management of hyperkeratosis for the lower leg. Now, instead of using wound cleansing and wound debridement, they talk about exfoliating the wound. And they talk about the prevention, the treatment, and the maintenance, but they talk about involving the patient in doing that. And they talk about emollients. And so we know from other areas of study like skin tears that if a patient moisturizes their legs, that it improves the limb health, decreases skin tears. So if once we get the ulcer healed, and certainly during the process of healing, that we use those emollients to decrease the prevalence of the hyperkeratosis. Now, the options for cleaning of methods of the skin, and again, these were questions from the first webinar, is can a patient shower? Can they shower with the wound exposed? Again, you as the clinician have to determine with your patient what are the risks, and you can see that showering can increase the risk of contamination, and if the limb, say it's a leg ulcer, isn't covered, then the cleansing agents that you use for washing your hair or your body can actually impact on that wound by changing the pH or the hydration of the skin. So if you have a patient with reoccurring infections or it's hard to heal, we recommend that, yes, get them in the shower, but cover that limb, let them shower, then they can take off the bandage and then wash the leg, wash the wound, as previously described. For the bathing, I do not recommend bathing when you have a hard to heal wound. As you can see that it increases the risk of contamination, the risk of change in pH and hydration of the skin. There's some mobility issues getting in and out, and it takes thorough cleansing, especially if it's used by other people. So in my personal opinion, it's not recommended. The benefits of it, it does allow for a whole body cleansing. I'm not a bath person, but I can't think of anything worse of getting in the wound, bath with a wound and having all that in the mix. For those in outpatient clinics or in the home situation, what we often do and what the community nurses do is use a clean bucket or bowl, and lined or not bowl, depending on how that equipment is processed. It's inexpensive and it's effective. It encourages that patient healthcare practitioner engagement, so you're helping take off the dressing. You're seeing how the dressing, how saturated it is, the condition of it. If the stocking is pristine, you can see if they've been wearing it or if it's ridden down. So it helps with that interaction. Cleansing, as I said before, it improves the well-being. Washing that with the moisture, with the fluid, helps soften that hyperkeratosis. And this is also good for immobile patients. The downside of it is having to gather your equipment, having to carry the water. The integrity and the equipment have to be checked at each cleansing, and it requires thorough and frequent cleansing of the equipment, but it's something we commonly do. The commercial cleaning wipes, it's convenient, easy to use, effective, it's safe. Again, it can increase the cost. It also increases a little bit on the environmental impact. And some ingredients, depending on which type you use, can increase sort of some skin reactions. Normal saline, and this comes from the questions that you keep asking, is that yes, it's convenient to use, but it's insufficient for skin cleansing, unless you have a healing wound and it's small. So what are some of the chemical agents recommended in this document, but also people have written to me and say, this is what I use. So this is not to be a totally comprehensive list. If you want to write in and give what you're using, then we can use some of those in the implementation webinar and the last webinar. So in the document from the Wounds UK, they talk about the salicylic acid because it helps exfoliate, but because it is efficient in that, you can't use it on healthy skin. And they also state that it's contraindicated with patients with diabetes mellitus. What we often use is zinc paste bandages, either with a preservative or non-preservative. It's slow, but it has some anti-inflammatory properties and usually very well tolerated by the patients. It's also good for decreasing that itching. It acts as a barrier to the scratching as well. The hydrogel sheets are good, they're soothing, and can soften those really hard plaques. The hydrocolloid dressings, it would have to just be a patch, but again, they do soften. All of these modalities do take time, and we use them many times in conjunction with other types. Pine tar was something that I wasn't aware of clinically, but this was sent in to me. Then I went and asked my other colleagues, and they said, yes, we've been using. An example of the pine tar would be pine tarsal. And it's a pH-balanced soap alternative, and it, as well as antibacterial, it has antifungal properties, and it also has anti-inflammatory properties as well. Some of my colleagues told me that they only use it for short periods because it can dry the skin a bit, but if you marry that with moisturizer, and also there's new formulations out that have addressed that issue. We also use topical steroids. Now, this is short-term. It does require prescription, but it does decrease that inflammation, and patients find that with good effect. This is sort of just a summary of talking about how important these emollients are for this hyperkeratosis. And they give this document, and any condition has sort of a spectrum of mild to severe. And so they talk about when it's severe, about some of the other properties that are required that I've talked about. Now, for application of aseptic technique in a wound dressing procedure, this is a consensus document published by Wounds Australia. Now, the third edition is not up on the website at present, but these are recommendations for doing a wound dressing procedure, and it has recommendations both for an acute care setting, aged care facility, or in a patient's home. So it takes you through those different scenarios, what equipment you used, how you can use equipment in the home versus in the hospital setting. So I commend this document to you. Now, this photo I'll conclude my presentation on before I go to the question and answering. This is a woman who had cellulitis, and so she has desiccated tissue epidermis. And she came to me before she was going to her physio appointment. She had just been discharged from the hospital, and her cellulitis had resolved. But because of that inflammatory infective process, the epidermis had lifted and desiccated, and she was left with this tissue. And she actually was going to physio because she didn't have range of motion of her ankle. And so in one go, painlessly, I was able to lift this non-viable epidermis off with scissors and a tweezer, put some emollient, some moisturizer on it, have her do dorsal flexion extension. Physio saw her, she had full range of motion, and she didn't need further appointments. She did stay in the compression to protect that tissue, that soft tissue that the epidermis had grown underneath. So some of my tips is that I talked about, if you can be putting your soak on the wound while you're washing that. I tend to use the 3-pack sterile gauze. I pour my solution in it, and I use a baby bottle warmer to warm my solution. You can also put in your pocket or a bowl of warm water. Remembering that you have to maintain those aseptic practices. I put 2 layers of the gauze on the wound, and I use the third piece of gauze. I open it up and tie it on. Then I put the antiseptic skin cleanser on my hands, and I massage that in. And with my bowl of water and face washers, I wash off the antiseptic wash. Remembering that you can't contaminate the water, so that anytime that you use an instrument or a cloth on your patient, you can't then reuse that. So you need to put that aside, put it in the linen skip, and get another face washer to continue the process. Because that water's clean, you can also use it for the other leg as well without cross-contaminating. You can shower, but I do recommend that you bag that, then clean the limb. Remember that you apply a pH neutral antiseptic or skin cleanser is our recommendation. So now if you have any questions, I'll open that up. I thank you for listening.